Well, I want to end by talking about some unusual locations of ectopic pregnancy. Most ectopic pregnancies occur within the ampullary portion of the fallopian tube, but occasionally you'll see ectopic pregnancies in the interstitial portion of the tube, which is the portion of the tube that travels through the myometrium to the endometrial cavity, occasionally within the cervix, here occasionally within the ovary, and occasionally you may see abdominal pregnancies as well. Of these pregnancies in unusual locations, it's the interstitial pregnancies that are the most problematic. These account for about 2 to 4% of all ectopic pregnancies, and the reason that these are of concern is that they are associated with a much higher morbidity and mortality, probably because these pregnancies have a better blood supply from the uterus and therefore can grow larger before they rupture. The end result is that very often these patients present late in gestational age with massive hemorrhage, and so significant morbidity and mortality to the mother. In addition, medical treatment much less successful than in ectopic pregnancies in other locations. So how do you make this diagnosis? First of all, you look for an eccentric location of the sac, and you can see that either the surrounding myometrium is completely absent on the serosal side of the ectopic pregnancy. So here you see myometrium on the right surrounding only about half of this gestational sac. The rest of it protrudes beyond the serosal surface of the uterus. Or you see significant thinning of the surrounding myometrium. And people have suggested that if you measure from the serosal surface to the edge of the trophoblastic tissue, if that myometrial rim is less than 5 millimeters, then you probably are dealing with an interstitial pregnancy. Here is another example where you can see that the endometrial stripe is empty, no evidence of intrauterine pregnancy. Here is the ectopic pregnancy here. You can see how vascular it is, and you can see that it is surrounded about 50% by the myometrium, but again, the serosal surface of it, there's no myometrium around it at all. So again, an interstitial pregnancy. A finding that's been described in the literature is an interstitial line sign, which means that if you look between the edge of the interstitial pregnancy, you can see a little echogenic line that connects it to the endometrial stripe. And this is an example from the literature. But what I think is actually, and I should say that that little echogenic line is believed to represent the residual of the interstitial portion of the tube. But what I actually think is more helpful is actually looking for a bit of myometrium that separates the edge of the gestational sac from the endometrium. And if it is, you see normal myometrium between these two structures, you know for certain that that little gestational sac cannot be within the endometrial cavity. And if it's surrounded in part by myometrium, it must be an interstitial pregnancy. Here's another example where you can see the endometrial stripe here. You can see the gestational sac. It is surrounded clearly by myometrial tissue, but note that there is about 5 millimeters of normal myometrium between the edge of the sac and the endometrium. This confirms that this eccentric gestational sac cannot be within the endometrial cavity, and it must be within the interstitial portion of the tube. Sometimes color flow imaging can be helpful because it demonstrates that you can see blood vessels directly feeding the gestational sac arising from the myometrial tissue, again confirming that this is within the myometrium and not just adjacent to the uterus. There is a differential diagnosis, and that would include a cornual pregnancy. Here is the eccentric gestational sac in these two cases, and you can see that the endometrial stripe clearly comes up to the edge of the gestational sac and in fact engulfs the gestational sac. That means that while this gestational sac in both of these cases is eccentric in location, it is clearly within the endometrial cavity and therefore in both of these cases within the right cornua. And this is something that you might see in a patient with a septate or bicornuate uterus. Occasionally, fibroids or myometrial contractions can also displace the intrauterine gestational sac and make it appear eccentric, and sometimes can mimic an interstitial pregnancy. Cervical pregnancies are also important to identify because they too have an increased risk of bleeding. These are an uncommon location of ectopic pregnancies. Risk factors include in vitro fertilization, prior D&C or C-section, presence of an IUD, Asherman syndrome or endometrial adhesions, as well as fibroids, but occasionally no predisposing factor can be described. And the problem with a cervical pregnancy is that if you think the patient is miscarrying and you do a D&C, the patient may end up with life-threatening hemorrhage. So in the past, these patients had to be treated with hysterectomy. Current options include systemic methotrexate, local injection of methotrexate or potassium chloride, or occasionally D&C with careful control of local bleeding, uterine artery embolization, or tamponade with balloon catheters. So again, there are some current treatments that can be performed that potentially could preserve fertility. Obviously a much better situation than having to do a hysterectomy. These are some older cases because again this is not that common, and what you are looking for is an intracervical location of the sac. So the uterine fundus will be empty, the cervical os will be closed, and you'll see the sac embedded within a wall of the cervix. You can see the embryo, the amnion, and the trophoblastic tissue. This often causes the cervix to increase in size, and it almost approximates the size of the uterine fundus with a waist at the level of the internal os, and that appearance has been described as the hourglass uterus. Here are a couple of other older cases. Again, you can see this gestational sac within the cervix, eccentric trophoblastic tissue embedded into the cervical wall. And here you see the little embryo and amnion with this very irregular gestational sac within the cervical wall. Early on, it can be very difficult to differentiate a cervical pregnancy, however, from a miscarriage. And here is a patient who came in with vaginal bleeding. You can see on the sagittal view of the uterus, the endometrial stripe is completely empty. Here is the gestational sac within the cervix. And we were pretty certain, or my residents were at night, that this was a cervical pregnancy because you can see it's eccentric. It's actually embedded in the posterior wall of the cervix. You can see it's quite close to the outer margin and separate from the endocervical canal. But in fact, it can be hard to differentiate this from a sac that is aborting within the endocervical canal. And one thing that might have been helpful for them to have done would have been color flow, looking to see if they could see a feeding vessel implanting within to the cervical wall. Here is a patient that came to us. We wondered if there was a cervical pregnancy here. You can see on the sagittal view the endometrial stripe is empty, and here you can see the endocervical canal. You can see the external os is clearly shut, and here is the gestational sac, and it's clearly eccentric, not within either the endometrial stripe or endocervical canal, but it's actually just above the level of the internal os. So here's the external os, the internal os. This is actually in the anterior, embedded in the anterior wall of the uterus, just above the level of the internal os. Here you can see it better on this sagittal image with the uterine fundus here, the endocervical canal here, and here's this gestational sac embedded into the anterior wall of the lower uterine segment. And this is exactly where a C-section scar is located, and this in fact is an ectopic pregnancy that has implanted in the C-section scar. And this location of ectopic pregnancies is becoming increasingly common as the rate of C-sections increase. And this is important to diagnose because it is associated with an increased risk of uterine rupture and severe hemorrhage. And in these patients, just like in a cervical ectopic pregnancy, D&C would be contraindicated, and these patients should be treated with either local injection of potassium chloride or methotrexate, or perhaps systemic methotrexate, or even surgery. Here is another example. You can see some fluid in the cul-de-sac, and here is the ectopic pregnancy that's located just above the level of the internal os, and you can see the edge of this ectopic pregnancy going all the way to the serosal surface of the lower uterine segment. So again, another ectopic pregnancy implanted in a C-section scar. Now this patient, initially we thought was a pregnancy of unknown location. She came in complaining of pelvic pain. We did an endovaginal ultrasound. We saw no evidence of intrauterine pregnancy, and we saw no evidence of an ectopic pregnancy at all. And this patient, we told her that we weren't sure where the pregnancy was, but it could easily be an early intrauterine pregnancy. She was not sure of her dates. And we advised her that she should come back for follow-up in a couple of days. And she looked at us and said, well, I don't really understand why you spent all that time examining my pelvis, because really I hurt up much higher up by my left kidney, and pointed to an area that she hurt just below her rib cage. So sure enough, we looked up there, and this is what we identified, a hematoma right in the region of her pain in the left flank. And this is a patient who had an intra-abdominal pregnancy in the left flank. And again, this looks like a pregnancy in the adnexa. It just looks like an adnexal hematoma, but it was in the upper abdomen. So again, intra-abdominal ectopic pregnancy is extremely rare, but it is absolutely critical that you always examine the area of the patient's pain, because that is where the pathology is likely to be.